إذن رمضان كريم للجميع. مرحبا بكم في سلسلة محاضرات الأفريكان Journal of Dentistry and Implantology. واليوم لنا الشرف أن نستقبل معنا الدكتور سام عمر الذي يأتينا من مصر الحبيبة، والذي سيقود هذه المحاضرة البروفيسور جعفر موحي. وبدون تأخير سوف أعطي الكلمة للأستاذ جعفر موحي لكي يقدم لنا محاضرة اليوم، والمحاضر الدكتور عمر سام. وشكرا.
هاي، مساء الخير جميع، رمضان مبارك كريم. Hi, Dr. Omar. I hope that the attendees will really enjoy this amazing lecture, and a dear friend. I'm very honored to be to chair this session with Dr. Sam Omar, talking about a field of dentistry he really controls, and he's really his topic of interest and of excellence. I was very happy to met him many times all over the world, in Asia, in USA, in many times in the biggest digital conferences and congresses. He's a brilliant young general dentist practicing in Cairo, Egypt. He has an amazing facility on digital dentistry and implantology, one day center, on the clinical center in Cairo. He has many positions in the university, in Cairo University, as in the prosthodontic department as a resident. He's an education manager of the digital department of Megagen Implant, member of R2 Digital Center Development and Education Team. He's flying all over the world to give this kind of science, or new science in dentistry, doing implantology in the safe way, perfectly being guided with systems more and more efficient, more and more accurate. I'm very happy to have you today with us, Dr. Sam Omar, and I'm really looking forward personally to this lecture, because every time we had a brainstorming on digital dentistry, I was amazed by your new trends with the vision, the future. I'm very happy to have you with us today, and please, you have 45 minutes for a lecture, and then we will follow with the 15 minutes discussion or a Q&R discussion. Thank you for being here. The stage is yours.
شكرا جزيلا Professor Muhi. Let me start with saying this in Arabic. Ramadan Kareem وكل عام وأنتم بخير. أعتقد ده أفضل شهر في السنة كلها، وشهر بنحاول يعني نريلاكس شوية ونبقى مع أهلنا، ودي أحسن حاجة. فأنا سعيد إن أنا قاعد معاكم النهاردة، و for me to spend time with you guys is the best way to use the time. To spend your time with family and friends is basically the best way to spend your time. So with this in mind, I don't want to take too long because we are very short on time. So let me start to share my screen and share the topic of today. Bismillah. Okay, I hope everybody can see my screen.
Perfect.
So essentially, my topic today is called Improving Upon Good Dentistry, a New Digital Update. So what I'm going to be sharing today is basically my personal journey of improving my own clinical practice. This is it's just a presentation from my point of view and how I'm seeing that now I'm really trying to improve everything that I'm doing, day by day. So that's essentially the idea behind today's presentation. So we'll go from, simple cases all the way up to slightly more complex cases. I'm very happy to share with you guys that I've recently just finally opened my own clinical practice. I do claim that I'm a general dentist, but I don't do a lot of general dentistry anymore. I like to focus more on implantology, and that's basically what I do most of the time. So I'm very happy to have opened one-day clinic and also one-day academy. So I've had a lifelong dream of mine to continue teaching people and to tell them about digital dentistry, and that's what I've been doing for almost 5 years now. I know we're still at the beginning of the road, but for me, I've always wanted to do something in my own country. So recently, we just launched the One-Day Academy, and I just love the launch of the Academy because I was really able to bring all my family, all my really close friends, and all the partners that we had that really helped us build One-Day Academy. So for me, it was a really special day. That was about 2 weeks ago. And the reason why I started this is because I've always been saying this. I have a dream. So me and this guy share one thing in common, which is we both have a dream, right? But my dream is a little bit different, right? My dream was I really wanted to make sure that I can teach everybody and every dentist in the world how to use digital dental technology. The reason why is because I believe this is the best way for you to provide better care for your patients. It's not just because digital dentistry is fancy. It's not. It's just a matter of it's actually better for your patient. And that's what I personally believe. And that's why, myself and Dr. JC Kim, who's my mentor and who's, one of those people that I'm really proud to have worked with him and I've learned from him for the past 5 years now. And we've been, touring the whole wide world, trying to teach people, the ideas that we have in mind. So we try to teach people things like digital oral design. So these are some of the pictures of the sessions that we've had together. And these, most of these sessions were actually in Germany, but we really enjoyed doing all these sessions together because, we love to share everything that we learn with people. And then what we try to teach them to do is to try to show them how we could use digital technologies like, smile design, digital planning, 3D printing, all these things that we can teach people for them to move their practice and to go from what we have on the left side and to change people's life and go to what we have on the right side. So this is basically what we're able to do with digital oral design. But today, I'm going to focus more on everyday dentistry. Let's talk about dental implants, which is basically my passion. I love dental implants. Let me show you how I personally believe I improved my implant journey. And it all starts with this case. So I've always been, placing implants guided. I believe that doing implants guided are the best way to place your implants. So that's basically why I believe we should always do our digital planning. So every case that I do, I try to do digital planning. And this was one of those earliest cases that I learned so much from. So this is how the patient looks like. We're missing one premolar that is broken right here. And the plan was to extract the tooth and to place an implant. So let's see. For my protocol, what I always do is I use a guide and I try to do immediate loading if possible. And we'll talk a lot today about immediate loading and how I think what would be the best protocol to do immediate loading. So we always start with this. We try to do atraumatic extraction whenever we can. So after we do that, we can place our implants nice and guided. We measure ISQ. And in this case, I got 65 ISQ. I'll talk a lot today about ISQ because this is one of the best pieces of technology that we have right now. And I think using it is very valuable. So I got 65 ISQ in this case. So what I decided to do was, I know that 65 ISQ is not enough to do immediate loading. So what I decided to do in this case is just use the provisional as a custom healing abutment. And I think a lot of us have done a similar thing before. But the interesting thing is, I noticed that there wasn't a big change in the tissue outline before the treatment and after the treatment. If I look at the final picture and if I look at the initial picture, not a massive difference. So why didn't we get a lot of change in the tissue contour? And that was really one of the earliest questions that I had. So when I read more about this, I found that what I did unintentionally, I didn't mean to do that, but by using this custom healing abutment, I actually minimized the amount of tissue change that happened. So we had this study that was done by Dennis Tarnow, Stephen Chu, and Maurice Salam, and David Garber. And what it did was, it showed us what would be the best way for us to do immediate implant placement. So would it be easier for us to just take out the tooth, place the implant? The first group, this is what we did. We placed the implant with a standard healing abutment. Group number 2, we placed the implant in a provisional. Group number 3, we placed the implant, did bone grafting, and we placed a large healing abutment. And group 4, we did everything. So we placed the implant, we did the grafting, and we did the immediate loading to support the soft tissue. And what we saw logically is the group where you do everything, which is the group on the right side, where we do the bone grafting and provisionalization, the amount of tissue change that happened become a lot more minimal. So essentially the idea was, if we use things like a custom healing abutment to support the tissue during the healing, that minimizes the amount of tissue change. I think a lot of us have seen this custom healing abutments, but I'm not showing you these abutments because I believe they are the best. This is what I used to think before. So let me show you how we do this. What I personally used to use before is something that is called the anatomic profile generator, which is basically a mold that you 3D print. You put your titanium base in there, and then you just flow a little bit of composite around it. And this is basically how you make it. It's very, very simple. It's very, very basic. This is how it comes out at the beginning, but make sure that you always make it nice and smooth and clean, right? So this is how it looks like after finishing. And this is the first case that I've used this on. So this is how the patient came in. She had this molar that needed to be extracted. We did the extraction. We placed the implant. And this is how everything looks like in the patient's mouth after 2 months. And it's obvious that we don't have a lot of tissue change, which is great. So let's see. Now, this is how the patient looks like after 2 months. This is after we remove the abutment to take the impressions, and this is the final restoration. Bone level looks acceptable. But do we always get the same result? Now, that was the question. So I started to use these abutments a little bit more, but if you see here, one of the problems with these custom-made abutments, but these are prefabricated abutments, is that they're not always the right size. So if you look here, it looks like we do have a gap between the soft tissue and the abutment. And I've done a little bit of grafting in this case, but I'll show you how the situation looked like at the beginning. In this case, I've placed the implant, I've done a sinus bump, I've done a little bit of grafting. So what's going to happen to my graft material in this case if I have this opening right here? And this is what I saw afterwards. After a few months, this is how the patient looks like. This is how it looks like after 3 months. It looks good clinically, but does it look good on a radiograph? And actually it does not. And look how much bone I've lost around my implant, even though I thought at the beginning that these abutments were actually good. So that's one of the things that you have to bear in mind. If you see something that looks good clinically, that does not mean that it looks good radiographically. And that's very, very important. So I started to do more with these cases, a little bit more, but this time I'm trying to change. And you know, the good thing is Megagen offers this system that is called the anatomic healing abutment or Megaline system. It's basically healing abutments that look anatomical. They're made out of titanium, which is good. I don't have to make them myself. So let's see. This is how the patient came in. We did the extraction, we did the implant placement, we placed the healing abutment as well. And this is how the patient looks like after 4 months. Again, the good thing is not so much change in the tissue contour. The change is quite minimal, and this is how the emergence profile looks like. If I zoom in a little bit on the emergence profile, I think the emergence profile looks absolutely gorgeous. But, and that's what we said, is the radiograph as good as the image? And that was the question. Actually, when we look at the radiograph, I'm not very happy with how everything looks like, because it looks like we've lost a little bit of bone. So I keep noticing that with these custom healing abutment, we still might lose a little bit of bone. And I'm wondering, why are we losing this bone? So let's see. This is another case with the anatomical healing abutments. I think they do a pretty good job with sealing the socket somehow, but it still looks like there is a little bit of change in the tissue contour. And this is how the whole case turned out to be. This is how the situation looked like at the beginning. You guys can see a few gaps, still a few gaps between the abutment and the soft tissue, right? This is how the emergence profile looks like. Again, it looks absolutely beautiful, but let's take a look at the radiograph. If we take a look at the radiograph, again, I still see a little bit of bone loss. So when when I ever see such issues, I always want to make sure that I know what's going on and what's going wrong. So I really wanted to check, why am I still losing bone even though I'm supporting the soft tissue? This is considered good, but can we improve upon what we have? So when I kept asking myself, why am I losing this bone around my implants? And I think the answer was, for me, a bit clear. How many times am I changing the abutments on the implants from placement until restoring it? How many times are we putting components on the implants and removing components off of the implants? How many times are we doing this? If we do one-stage surgery, which means that we place the healing abutment at the time of the surgery, we do it 7 times. 7 times of removing things and putting things on top of the implant. If you do 2-stage, you do it 9 times. Does that really affect us? Does that change anything for us? Actually, there was a study that was done in 1997 by Abramson and Lindy. This study was done in beagle dogs, and it showed that removing the abutments from on top of the implants more than once, you start to lose a little bit of bone. So this is what they've done in the study. They assessed, they removed the abutments multiple times, and they saw how much bone loss we have. And what they said, the conclusion was, if you remove your healing abutment more than once, you lose a little bit of bone. So can we find a way for us to minimize the amount of times we remove the abutments from on top of our implants? How can we minimize the amount of times we remove the healing abutment? That's a very important question. Now, the answer was this. It's actually a possibility. But if we need to make sure that we keep the healing abutment the whole period of the healing, what we need to come out with is, we need to come out with a smart solution. And that's what we got with this scannable healing abutment. And I need you to really take a look at this very smart idea. So the scannable healing abutment, from its name, is a healing abutment that you can scan. The reason why is because, as we said, we don't want to remove the healing abutment at the time of the healing. So that's why we developed this thing called the scan healing abutment, which I believe is a very smart idea. So what is this composed of? So at the bottom, we have this healing abutment portion, and right on top, you can just clip a cap. This is a plastic cap, just like the guys that use CEREC are familiar with this concept. It's just a cap that you clip on top of the healing abutment when you'd like to scan. So let's see how that will change things for us. This was one of the earliest cases I've used these abutments. So this is how the patient looks like. She's missing a few teeth. And this is how her situation looks like. Obviously, the situation is not very good, but we wanted to place a few implants here. I always do my planning digitally. The reason why, because I believe this is the best way for you to do your planning, is to do it digitally. And I do it in this case in R2Gate software. We've designed the guides with 3D printed the surgical guides for our patient. And at the time of the surgery, we placed the implants and we placed the scannable healing abutments that we just spoke about. So what's very important for us to notice is make sure if you use these abutments, you have to take a radiograph and make sure that they're seated down all the way. Just like you do with a standard impression coping. You have to take an X-ray to make sure that the impression coping is seated all the way down on the implant. Exactly the same thing for the scannable healing abutment, because it acts exactly like an impression coping or a scanned body. This is how the patient looks like after 1 week. The healing looks fine. I'm happy with this. And at the time of the final restoration, this is how the patient looks like. All I do is clip the right cap on top of the healing abutment. And now I can go ahead and scan my case. The good thing is I did not remove my healing abutment. And that's the key for us to minimize the bone loss. The only time I have to remove the healing abutment is when I'm delivering my final restoration. So it looks like the tissue looks quite healthy, and that's exactly what I want. When I place my final restoration, I'm happy with the result that I have. So the good thing is I showed you how the X-rays of the previous cases looks like. Look how the X-ray on this case now looks like. Previously, I showed you that the bone level was below the implant. It stops at the first thread. But right now, the bone level is above the implant. And that's exactly what I'm trying to look for. I'm trying to improve everything. I'm trying to preserve the bone by using scannable healing abutments and not changing them or not removing them during the healing. Now, let's talk a little bit more about something different. Let's talk about these protocols that we hear a lot today, things like socket shield. Is there any way we could use socket shield in a guided fashion? Let's talk about that. So this patient on the left side that we can see, she had a few broken teeth, and she had, this is a canine, by the way. So we wanted to place 3 implants for this patient. Again, I always do my planning in R2Gate software, and then we'll go ahead and use guided surgery to place our implants. I prefer to use, this was one of my earliest cases also using the socket shield technique, but I'm telling you that it did make a big change for me. So let's see. So this is how everything looks like. I used the root membrane kit from Megagen to do that. And it looks like I was able to remove the whole palatal segment or the lingual segment of the root, and to confirm the bone level or the shield level, it looks like it's around the crest of the ridge. So this is what we want. The next step for us is to place the implants and place the scannable healing abutments. And again, make sure when you place them, you take an X-ray and make sure that they're seated all the way down. And this is how I suture the patient up. After 4 weeks, this is how my patient looks like. Right now with the implants that we have, after 4 weeks, you could do your scan or you could take your impression because you could do your loading at that time. And this is how the final restoration looks like for this case. It looks good clinically, but as we said before, we always need to check the radiograph. And on the radiograph, this is how it looks like. I'm very happy because again, the bone level is above the implant. That's what I've always been looking for. For all the implants, the bone level is above the implants. And the beauty of the socket shield technique, if you look on the left side, it looks like the site where we've done the socket shield in, looks like we do have a nicely preserved tissue volume. And again, that's one of the things that we're looking at. Great. So this is using socket shield, and this is a nice technique, and using scannable healing abutments. The one thing that I hear a lot of people are talking about is they keep saying, and that's one of the things that made me think twice before I use socket shield. People keep saying, oh, it's a very technique sensitive procedure. It's very technique sensitive. And I spent a little bit of time with my good friend, Dr. Howard Lockman. And according to him, the most difficult part is reaching the apex of the tooth when we're doing the separation, is reaching the apex of the tooth. So the beauty of guided surgery and digital dentistry is that it helps you do difficult things in a lot easier way. So is there any way I can use my standard root membrane kit with the aid of guided surgery for me to do guided root membrane or guided socket shield? And that's when I developed this thing that we call the Apex Guide. So the Apex Guide is something that I thought about, which is basically, it's a surgical guide that allows you to reach the apex of the tooth. So how can we use that? So essentially, the idea is very simple. It's very, very simple. What we do is we 3D print this plug, and we place this plug inside of our surgical guide. The idea behind this plug is that it narrows the diameter of the surgical guide for us to be able to use the golden drill in the socket shield kit from Megagen. We could use it directly through it. So this is how the kit looks like. And again, this is essentially how I use it. As you guys can see, I'm using this drill directly through the Apex Guide, and it helps me reach the apex of the tooth, and that's exactly what we want. So let's see how we do this. At the beginning, I used to use Gates Glidden. I don't use this anymore. And then I use the first drill, which is the Apex Guide. I use the golden drill through the Apex Guide for me to drill all the way down to the apex. Very good. So now that I've created this channel that goes all the way down to the apex of the tooth, now doing the separation of the tooth is very easy. All I need to do is just go mesial and distal, since I've already reached the apex of the tooth, right? After that, we could take out the lingual segment. Again, the great thing is it always comes out nice and intact because you're doing it guided. And that's the great thing about using this guided socket shield technique. Very nice and intact. After that, we could do the preparation of our shield. And then I use a second guide, and that's very important. Two guides in this case. The first guide is the Apex Guide. Think of it as an endodontic guide. And the second guide is for the implant placement. The reason why is because the direction of the tooth is different than the direction of the implant. So that's why we need to use two guides in this case. And again, after I place my implant, I can place my scannable healing abutment. Very good. Now, this is the X-ray to confirm that it's seated down all the way. After 7 weeks, this is how my patient looks like. The soft tissue is nicely preserved thanks to the socket shield technique and also to the scannable healing abutment. At the time of scanning, clip the cap right on top, do your scan, and then you are good to go. This is our final restoration. We have to make sure that we take an X-ray to make sure that the bone level is nice. There we go. We took an X-ray. Looks like the bone level is above the implant. And again, that's what we always try to aim for and to hope for. More cases with guided root membrane. The good thing is this is an aesthetic case. This is how the patient came into our office. She had this tooth that was broken, but this was temporarily cemented in place. Tooth number 21, this tooth right here. Okay, so what did we want to do? So we took off the crown. This is how the patient looks like without the crown. Obviously, the tooth is unrestorable. This is our Apex Guide that we use. We place the Apex Guide inside the patient's mouth. We use the golden drill from the root membrane kit of Megagen. We go all the way down to the apex of the tooth, right? So once we've created this channel inside of the tooth, you can now use the initial shaper burr to cut the tooth in two halves, as we can see here, and take out the palatal segment. Again, the great thing is it always comes out very nice and sharp. And then this is how the shield looks like after preparation. Next step, guide number 2. Guide number 2 is the implant guide. Put that inside of the patient's mouth, drill for your implant, place the implant fully guided. If you end up with a gap between the shield and the implant, you can always graft this gap if you would like to. And this is actually the recommendation that we got from Dr. Hayashi in Japan. And this is a prefabricated restoration. One of the things that I like with Artogate software is it allows you to design what we call a prefabricated restoration. A prefabricated restoration means that this will be designed before the surgery, and that's one of the great merits about our R2Gate software. And now at the time of the surgery, all I need to do is I need to place that inside of the patient's mouth. The good thing is the tissue trauma is very minimal, and that's one of the things that make me happy, right? And then what we do next is we make sure that it's out of occlusion, whether it was maximum intercuspation or lateral movements or protrusion movements. So the crown needs to be completely out of occlusion, and the patient must be instructed not to bite on it. And this is the X-ray at the time of placement. So this is regarding smaller cases, and this is how I personally went through using standard healing abutments to custom healing abutments to scannable healing abutments and socket shield. Let's move on to another topic. This topic is going to be immediate loading. So this case right here, this is a patient that came to our office. He had really bad teeth, like extremely bad teeth. All the teeth were out of placement, as you guys can see here. And most of the teeth were actually mobile. So what we wanted to do is we thought that this would be a good candidate for us to do immediate loading on. So the plan in this case was to extract all the upper teeth and place 6 implants for our patient. This is how the planning looks like inside R2Gate software. We planned 6 implants in this case. And again, one of the great merits of R2Gate software is being able to design and print or mill a prefabricated restoration. And also what's really good is that it also allows you to export a model that tells you what the implant positions is going to be. So the way you use this model is rather than cutting the abutments after the surgery, you could just cut them before the surgery. And that's also one of the things that I really like with using this software. So this was our prefabricated restorations. We have pre-cut the temporary cylinders, and we have gaps between the restoration and the cylinders that we will use to flow a little bit of resin to pick up our restoration after the surgery. So this is my armamentarium before the surgery. Everything is ready, and now we're good to go and to do our surgery. At the time of the surgery, we extracted the teeth that were mobile. We kept the canines to use them to support our surgical guide for more accuracy. It's always better to use the teeth for support. So always do that. We placed 6 implants. We placed the temporary cylinders that were pre-cut, so we don't need to cut them after the surgery. And we've done the pickup, and this is how the restoration looks like immediately after the surgery. And this is how our patient looks like. And again, I think it's completely life-changing. I love the fact that we have access to technology that allows us to change people's lives in one day. It doesn't matter if you do it with R2Gate. It doesn't matter if you do it with Blue Sky Plan. It doesn't matter if you do it with any software you want. Again, the most important thing is we have access to great technology. Use it. But if you want to do immediate loading, make sure that when you do immediate loading, you know how you're doing it and you know how you're basing this upon. Immediate loading is a science that has criteria. So let's talk about the criteria that we need for immediate loading. The question that we get to ask to everybody is immediate loading safe? This is a question that I know a lot of people are asking. Is immediate loading safe? Now, the answer to this question is yes. Immediate loading is safe, but if done properly, that's very, very, very important. If done properly. So what exactly do we mean by if done properly? Because, I mean, this is, extremely important to know. So for us to understand what if done properly mean, we need to talk about 3 things. I'm sorry, guys, this is the very boring part of my lecture. This is the very technical part. Please bear with me. For you to assess your implant's primary stability, you need to make sure that you know 3 things. You need to understand what peak insertion torque means. You need to understand what resonance frequency analysis means, and you need to understand what implant stability quotient means. Peak insertion torque resonance frequency analysis, and ISQ. These two things towards the end, resonance frequency analysis and ISQ, are the same thing, but I'll explain why I put both on the board right now. I think all of us know what insertion torque means. Peak insertion torque means that when you're placing your implant, how much resistance are you getting? How much resistance are you getting to your implant placement? But the most important thing for you to know is that this is a one-time measurement. How many times do you place your implant? You only do that once. So it's very important for you to know that this is a one-time measurement. But Dr. Michael Norton said that we're not carpenters, we are clinicians. And primary stability is not only insertion torque, right? So there are other factors that also come into play. So what other factors do we have to consider? And that's why we talk about resonance frequency analysis and ISQ. So resonance frequency analysis is the principle. This is the main idea. And we measure resonance frequency analysis by a measurement unit called ISQ. Just like we measure our weight with a kilogram, we measure how much resistance we have to lateral movements by using ISQ. So let's talk about this one more time. Again, the main differences between torque and RFA is the fact that torque measures the resistance to rotational movement. On the other hand, resonance frequency analysis and ISQ measures the resistance to micromobility or lateral movements. Now the question is, which type of force is our implant subjected to? Is it rotational movement or is it lateral movements? Actually, it's mainly lateral movement with a little bit of component of rotational forces. So it's very important for us, if we want to decide if it's safe to do immediate loading or not, is to consider both of those, not only one. So we have 3 clinical scenarios where we might do immediate loading. So if we have a single restoration, or if we have multiple restorations, or if we have a full arch restoration, right? So if we have a single restoration, if you get 45 Newton centimeter insertion torque and 75 ISQ, it is considered safe to do immediate loading. If you get 40 Newton centimeter and 70 ISQ, and you're doing a bridge where the implants are splinted, it is considered safe to do your immediate loading. And if you do a full arch restoration and you get only 30 Newton centimeter and 65 ISQ, you could do immediate loading. I need you to notice how the numbers are going down. The more implants we have, the less the numbers need to be. We started out with 45 insertion torque, we ended up with 30. We started out with 75 ISQ, and we ended up with 65. The reason why is because we have what we call cross-arch stabilization. The more implants we have, the less strong the implants need to be individually. Very good. So now that we understand that we need these 2 criteria, ISQ and immediate insertion torque, now it's easier for us to decide if we could do immediate loading or not. But do I always get 45 Newton centimeter and 75 ISQ? Definitely no. Absolutely no. So what would you do in this situation? So in this case, I had this patient. She was a 20-year-old woman that came to us, and she was missing 2 lateral incisors. Of course, what I wanted to do for her is to digitally plan her case and to do immediate loading for her after I place 2 implants. So let's see, this is everything before the surgery. I planned my prefabricated restoration. This is how it looks like. This is how the clinical situation looks like for our patient. 2 missing laterals. We used our R2Gate surgical guide. We placed our implants fully guided. These were mini implants. We placed our implants fully guided, and we only got 25 Newton centimeter. And we previously discussed that we need 45, not 25. In this case, I really wanted to see how good, the restoration looks like for our patient. So I tried it and it fits, but I remembered that I need to measure ISQ too. And when I measured ISQ in this case, I got only 68 ISQ. If we go back to our criteria and we said 25 Newton centimeter and 65 and 68 ISQ is not enough for us to do immediate loading for our restoration. We need 45 and 75. So in this case, the best thing to do is not to load the restorations. And in this case, we sutured the patient up and we did not load our restorations because we know that this would not be the right thing to do. So it's very good that we have criteria. But what I want to tell you is I did not learn this the easy way. I learned this the hard way. And did I ever get failures with this system? And after using ISQ and doing insertion torque? Well, yes. Let's talk about failures. Let me show you some of the failures that I faced with this system, right? So this is one of the earliest cases that I've done. I wanted to do immediate loading for this case. This was my cousin, again, Ibn Ammi, and I wanted to try something new on this patient. So I wanted to do immediate loading for this case. 2 missing molars, and we wanted to do immediate loading. So let's see what we've done. We've done the planning in R2 gate. We measured the bone density. The bone density is quite high. So I think it's a good idea to do immediate loading. We exported the models from R2 gate software, and then we designed and 3D printed our restorations. This is how everything looks like. And this is my armamentarium before the surgery. I'm ready to do my surgery with my guides and my restorations. I open the flap. We've done the drilling through the R2 gate surgical guides. This is how the drill looks like. We place the implants fully guided, and we got 45 Newton centimeter, which is great. That's what we want. We measured ISQ in this case, and we got 79 ISQ for implant number 36, which is also great. We got 46 ISQ, and we got number 46 implant, 75 ISQ. So I think we have the numbers that we want. We got 45 Newton centimeter. We got more than 75 ISQ. According to the criteria, it looks like we could do immediate loading. So that's what I did. I immediately loaded our restorations, as you guys can see here. And this is the other tooth as well. And this is how the patient received his crowns. But look what happened after 6 weeks. So this is how the patient looked like. And he came to me and he gave me his implant along with the tooth and said, there you go. Itfaddal. These are my implants and my teeth, right? Of course, this is the one thing that we all hate to see. So this is how we looked like at the beginning, what we have on the top. And this is how it looks like after I lost my implant. Well, now we need to start and to think a little bit. What exactly went wrong in this case? So what I learned by this case is it's not only scientific criteria, because other factors also come into play. And these things are what we call the patient-related criteria. So what do I mean by patient-related criteria? I mean patient's compliance, I mean oral hygiene, and I mean occlusion-related factors. Let's talk about those in details. Number 1, patient's compliance. You always need to make sure that you select your patient. I know a lot of people say case selection, case selection, case selection, but actually this is very important. Why is this important? Take a look at the case history and ask the patient, how did he lose his teeth? Do you think it's a good idea for you to do immediate loading on a patient that doesn't really care about his teeth? I don't think this is a good idea. You only need to do such cases where patients that really care about their oral situation or their oral hygiene and all that. So patients must be educated about the nature of this procedure, and optimum care must be taken care by the patient. Also, take a look at the patient's hygiene. Do you think this patient has good hygiene or not? That's also very important. only do immediate loading procedures for patients with good oral hygiene to increase your success rate. And that's also a piece of advice that I'll give to you. I know the book doesn't say that, you know, we don't get this criteria, but I'm telling you, this is really important. Now, question number 3 is occlusion-related factors. When I said that we're going to be doing immediate loading, now the question is, if we do a single restoration, do we do it in function or do we do it out of function? Should it be in occlusion or should it be out of occlusion? And the other important question is, if it's out of function, how long does it stay out of function? Because you guys know that there's such thing that we call over eruption. So in this case, my tooth was actually in occlusion. When I look back at the pictures, it looks like I do have this occlusal mark. So my tooth was in occlusion. But my question is, if it's out of function, I believe we need to make sure that if we do immediate loading, put the tooth out of function. And I believe that this is the best way, because even if some over eruption happens, at least you'll be past the dangerous stage. But I'll also tell you one more thing. Now that I look again at this case, I don't think it's a smart idea to do immediate loading on a single missing posterior restoration. I think it's too much risk, and I believe it's not worth it. So doing single restorations immediately loaded in the posterior region, for my point of view, I don't think it's a good idea. So did we manage the failure somehow? Of course, we always need to make sure that we manage the failure. I mean, the guy is my cousin. ابن عمي مش هسيبه كده يعني. We need to fix the issue. So we've done a little bit of cleaning. We placed another wider implant. We waited 3 months for us to put the healing abutment. So this is how the patient looks like after 3 months. Now, after 4 months, now this time I learned from my mistake and I take a little bit more time, right? So after 4 months, we measured ISQ and we got the highest ISQ I have ever gotten on a patient until today, 88 ISQ. So it's really great that we went from utter failure to success by using a very smart tool like ISQ that allows you to know how the situation of the implant looks like. And of course, as we learned from our mistakes, make sure that your crowns are out of occlusion and lateral movements. And that's very important. And this is the final restoration for our patient. So what I want to say is, why do we use ISQ? The reason why is because it gives us an objective measurement of implant stability, and it helps us make a good clinical decision about loading or unloading, right? So this is the case that this is my last case that I'm going to be sharing with you guys today. This is one of the best learning cases I've ever had in my career, my very short career, right? So let me share this case with you very quickly. Last case I'm going to be sharing today. This is how this patient came to our, he came to our university this way. This is a university patient. He lost those central incisors in an accident. So we wanted to restore those for him. We've done the planning in R2Gate software. As you guys can see here, we placed 2 implants and we plan to do immediate loading. So I've designed prefabricated restorations for him. I've designed restorations, and now at the day of the surgery, we placed our R2Gate surgical guide. We've done the drilling through the R2Gate surgical guide, placed our implants nice and guided. We got 78 ISQ for one implant and 64 ISQ for the other implant. Now, you know, what should we do in such case? These are 2 central incisors. Should we place one and not the other? Should we place both? Or should we not place either of them? And this was one of those cases where it really puts you in a bad situation because, I mean, 2 central incisors, right? So I believe the right decision at the time is not to load the implants. But that's not what I decided. What I decided in this case is I decided to do the loading, which was a big mistake. And I'll teach you, today why it was a big mistake. So we placed the 2 restorations, as you guys can see here. You know, and to be safe, I put them out of occlusion. And then this is how the patient looks like immediately after the surgery. Immediately after the surgery, everything looks fine. But this is how the patient walked out this day. He walked out with 2 teeth. I think it's a great change. It's a very big improvement for the patient. On the other hand, after 18 days, this is how the patient looks like. He came back with 1 broken crown, which was the crown that had only 64 ISQ. After further investigation, we lost this implant. So the implant that we got 64 ISQ in, I mean, what do I expect? If you need 75 ISQ, and in this case, you did not get 75, you got only 64, and you got a failure, I mean, it's you know, something that you should expect. So how did we manage this? We did a little bit of debridement. We did place another implant instead of the other implant, and we did a little bit of grafting. And now I've done an even bigger mistake in this case, is that I've loaded the fresh implant, or actually the implant that I placed before. I've loaded it with 2 teeth. Again, I need to make sure that we follow this part. So I had 1 implant that I lost and 1 implant that survived. Ideally, what I should have done is removed both crowns to make sure that my implant survived. But my mistake here was the implant that was placed 18 days ago was now loaded with 2 crowns rather than 1. Can you imagine? Big mistake, right? So when I saw the X-ray after 6 more weeks, imagine how much bone I've lost around the implant that I previously placed at the beginning. This is the surviving implant number 21. Look how much bone loss I have around my implant because I've loaded it too much. So after 6 more weeks, when I measured how much stability that I got for this implant, I saw that I got 54. So the implant that had 79 ISQ or 78 ISQ at the beginning is now dropping in value, which indicates that this implant is failing. But because I can assess that the implant is failing, now I can try to save my implant by doing what we call unloading. So there was this study. I know unloading is a very unfamiliar term. What do I mean by unloading? There was the study that was done by Sinerby and Meredith, and it showed that unloading the implant for 6 weeks might give the implants a chance for them to regain strength. And that's what I did. So I decided to unload this case. I've removed the crowns, and I've done a Maryland bridge for our patient for 8 weeks in this case. After 8 weeks, look how the bone situation looks like. So this is how it looked like at the left side at the beginning. And look how much bone we regained. So now we're getting the bone back again. And that's because we did what we call the unloading. Now, the great thing is, now that the implant is picking up and the stability is regaining, so we've done the scan of our implants. We've scanned the implants. We put low profile healing abutments. In this case, we've also decided to place provisional restorations in this case, and we delivered a screw-retained temporary bridge that joined both the implants, and we kept it for 10 months. After 10 months, the implant that had very low ISQ, we measured ISQ for this implant, and we got 78 ISQ. So it's picking up ISQ again. And again, that means that we saved the implant that was already failing. And this is how the final restoration looks like for this patient. And again, was one of the best learning cases that we've ever worked with, because ISQ let us know that the implant is failing, and it allows us to take a decision, which is the decision of unloading, right? So what I want to say is we just want to make sure that we follow the criteria always, and hopefully that when we follow the criteria, everything will work out. So the criteria is, when do you do the loading and when not to do the loading? If you have very high numbers, I think this is one of the most important slides today. If you get 70 to 75 ISQ, you could do immediate loading if you want. If you don't want to do immediate loading, you could do 1 stage. which is putting the healing abutment. If you have 65 ISQ to 70, you could do a 1 or 2 stage if you want, and you could do early loading. By early loading, which means that you can wait only for 6 weeks. If you get 60 to 65, that means that this is quite medium stability. So ideally, don't place your healing abutment and do traditional loading, which means wait for 3 months. And if you have low than 60 ISQ, in this case, monitor your implant because your implant might be at risk. So this is the recommendation on when to load your implants. And that's what I believe one of the best merits of digital tools like ISQ. So as I told you, this is my last case that I'm going to be showing today. So these are just my takeaway points from today's presentation. I hope I did not take too long. Using digital planning and guided surgery is definitely key to free ourselves from complications and anxiety. Using tools like the scannable healing abutments can dramatically improve the bone level around your implants. Using digital devices like ISQ will help us make good clinical decisions regarding immediate or delayed loading protocols. And last but not least, procedures like PET or socket shield or root membrane will help you preserve the tissues and now can be done guided. If it's done guided, it's less technique sensitive and it's more predictable. Thank you so much for listening. I hope I did not spoil your Ramadan and take too much out of your time. Professor Mohyi, the mic is back to you.
Thank you. You were just perfect, my dear. It was very clear as usual. And I'm very happy to see that there is still some lecturers talking about failures and showing even cases where a part of the attendees will find solutions or say, I would do this and I would probably succeed in this case. And it's very pleasant to attend this kind of lecture where you can really talk without any complex on your failures. And for that, I really congratulations. It's very nice also to see that the resonance frequency analysis, which is a 25 years old tool. And what is amazing is that Neil Meredith was in his PhD program at the same time with me in Gothenburg University. And Lars Sennerby was the thesis director of both of us. So I attend all his testing on for resonance frequency analysis. He did everything on wood, on metal, on bone, fresh bone. It was very exciting to see him doing all those testings on different kind of materials. And I'm very happy to see that and I agree with you, it's something we need to use daily to see if an implant is really usable for an immediate loading. I don't know how we can see if there is questions from the attendees, but I have 1 or 2 questions for you. Dr. Skali, do you have any questions in the back? We cannot hear you.
لا أود أولاً أن أشكر الدكتور عمر سام على هذه المحاضرة القيمة. Very interesting, very amazing. أحسسنا أنك كنت كانت عندك إرادة أن تقسم معنا كل المعلومات في هذه التكنولوجيا الرقمية التي تعطي الكثير اليوم في طب الأسنان. وأهمية الESQ في immediate loading. اليوم شفنا أنه مدى أهمية هذا الماتيريال، أنه لازم يكون العيادات والأطباء الذين يريدون أن يستعملوا هذه التكنولوجيا وأن يستعملوا immediate loading، مدى أهمية أنهم يكون عندهم مثل هذا الماتيريال. فشكرا جزيلا ونتمنى أن تكون معنا قريبا في محاضرات أخرى إن شاء الله. شكرا.
Inshallah.
So, but do we have time for one or two questions?
Yeah, you can.
We need to finish at you have 1 hour for the Zoom period, or we can have time?
We can.
Okay.
More.
So, my dear Omar, I have just one question. I was very interested to what you show, the combination of the insertion torque and the ISQ value, and to take both of them, of these two values, to decide if you can load or not your implant. My first question is, when you show this 25 Newton centimeter implant, when you decide that you cannot, for this missing lateral, imagine that you have 2 or 3 implants with the same value. Do you think you have a kind of mathematically way to see things? If you have a low values and you have many implants, are you going to trust the fact that they will work together, and you will decide, even if the values are low, to use the to do an immediate loading? This is my first question.
Well, I think what you just said, Professor Murhi, is very important, and this is actually a situation that we face a lot. Is that, let's say if we're doing an all-on-6 procedure, most of the time, not all of the implants have the values that you need to do for immediate loading. The good thing is that we saw from the graph that was provided to us by Ostel is that the more implants you have, the less the numbers need to be individually. Because for some reason with implants, it's not 1 + 1 = 2, it's more 1 + 1 = 3, which is also one of the great things that we have. So I would still go with the recommendation. The recommendation for these cases is if you get 30 Newton centimeter, and if you get 65 ISQ, do the loading. This is what I personally see. So my personal preference, if we get a case where we have these numbers, 30 Newton centimeter, 65 ISQ, do the loading. If you don't have enough ISQ on the implants, try to exclude those out of your prosthesis. I know it becomes a bit challenging if some of these implants are in the middle of your prosthesis. If they are in if it's a terminal implant, which means that it's toward the end, you can always make your prosthesis a little bit shorter. If it's in the middle of your prosthesis, then there's not much that can be done. Just don't load this implant.
Okay. So my second question is, you can imagine that it's the continuing reflection on this kind of situation. What do you prefer, to let an implant healing outside the framework, or are you going to use the stability of the surrounding implant to make them keep this implant totally immobile inside the framework?
What I personally would do is not use the implant.
Okay.
Because I've had some of my personal cases, which are definitely not so many, but what I've seen is that this is definitely not the best way to go, because still the implants are, even if the framework is there is still a little bit of component of lateral movements that the implants are subjected to. So that's why I would prefer in such cases is not to load these implants at all. But again, it's just my personal preference. That's what I would personally do.
There is many biomechanic papers showing that inside the arch of the framework, you really have a kind of stability in the 3 axes, X, Y, and Z.
The cross-arch stabilization.
Because, absolutely. And I totally agree with you. When the implant is in the posterior area, you have to leave it. And unfortunately, those implants are the worst ones for the ISQ.
Yes.
So we agree that when we have implants in the second premolar, first molar, and even in the tuberosity area, just let them heal without any. But most of the patients, they do not need those implants because they just looking for an aesthetic outcome, and that's it. So if we stop the provisional in the second premolar, it's okay for the patient. He do not need in this particular period. He do not need more than that to be happy. Okay?
I agree. And if you don't mind, I'll add just one more thing. I know that a lot of people right now are doing all-on-4 cases. In my hands, just all-on-4 does not really work. Absolutely. The reason why is because, as you may know, it's all-on-4 or none-on-3. That's what they always say. So what I personally do right now, the protocol is always 6 implants. That's usually the minimum, because if you get one implant in the middle that is not strong enough for you to do immediate loading on, at least 5 more implants can take the load. And that's always better than 4 implants with 1 implant that is not ready to receive any load. So it's just, I think, with a little bit of time, you learn how to, just tweak your protocol a little bit for you to do what's good for the patient and what's also good for you. Yeah. So that's my personal opinion.
I have a question for Dr. Sam Omar.
Yes, sure.
If we don't have a scan healing abutment, if we don't have a scan, what the procedure you propose? What the process?
That's just a phenomenal question. I love this question. So I was just watching a lecture a couple of days ago by Marcus Hertzler, and what his protocol is that he takes the impression at the day of the placement of the implant. Right? So this is probably the best way for you to still do the same thing, but without the custom healing abutment or without the scannable healing abutment. It's just, and to me, to be honest, it makes a lot of sense. I want to start to use his protocol. For some reason, I don't know why I didn't think about this before, but probably taking the impressions at the same day is a very smart way to do to reach the same result.
This is what Alain Simon-Pierry do since 15 or 20 years. He can provide to his lab the impression the same day, and within the 24 hours he can place the implant. And it's very interesting because even if you have a small misfit, it will act during the osteoclasis period of the implant. So it will not have a real negative effect on the implant. I'm saying even if, but you have to avoid that and to take all the security to have the best impression and the best with the. My last question, Dr. Asqali, do you have any other question?
No.
Okay. My other question, and it's a question and it's a suggestion. That's why I told you that when you following this kind of lecture with failures, you automatically go and say, if it is my case,
yes.
What am I going to do? And this is a very, very interesting exercise because it will push you to know if what you are doing, but you need to be honest with yourself.
Yes.
I mean, it's very easy to criticize. No, you have to do this or that. But we all have a lot of cases where when we show the case, a month after the surgery, we said, I'm stupid. I had to do this like this, or I have to avoid this this kind of flap design or this or that. But you need to be honest. That's the biggest problem with implantologists. You need to be honest with yourself and see that you can do some mistakes, and you can have the courage to show and to discuss those kind of problems.
Right.
So for the 2 incisors, when you have 2 values, 2 ISQ values for the 2 incisors
that are different,
one was acceptable, the other one no. What I would do, and what I'm doing every time I perform an immediate loading of my implants, is to have a very, very strong reinforcement of the crowns. And I think that I suppose that your patient didn't come to see you immediately when he fractured the implant.
That's true. That is very true.
This is what I guess.
That's true.
It's not because he's not aware of the problems. Probably he do not feel it, because sometimes you just have a crack. Yes. And at the time, the patient cannot feel the fracture with his tongue. Right. He cannot know. He can absolutely not know if there is any kind of problem. And I think this implant who was in the beginning in a so-so attitude, if you perform 2 provisionals with 2 solidarized crowns,
bonded, yes,
a real framework, I think those 2 incisors probably will have a better outcome. This is just a personal opinion, and this is how I will do. I never put a provisional on an implant except when we have a single tooth. I never do it without a very strong reinforcement. So this is just an
I agree 100%. You know what's really funny about this case is that it puts you in a very odd and weird situations. There's one tooth that you can load and the other one that you can't, right? And the complete lecture, because this is just a brief part of this whole lecture, it's a big lecture about failures, and I promise you have a lot of failures, but I don't mind sharing them because it's fine. This is how we all learn. But bonding is actually a very important part, and I have failures that happen due to bonding, because in these cases, I showed you that I might have done a little bit of bonding between the 2 crowns, but we need to always remember a few things. If you do something, you have to do it right. Bonding means bonding. It needs to have a proper protocol. You need to make sure that you do a little bit of sandblasting or a little bit of roughening. You need to apply bond. You need to apply a proper bonding material. And that's not what I did. I just used a little bit of flowable composite in between, and that was it. But again, it's just, this is how we learn, doing these little mistakes.
Absolutely.
What you need to do is you need to share this with as many people as possible.
Absolutely.
And we always tell people, criteria are there for a reason. It's for you to follow them, right? But you need to follow them without being blind. You need to understand why we have these criteria. And that's essentially, the whole purpose behind today's lecture. I have 2 little things to add. The first thing is why, Professor Mohi, you just told me that, people have been taking impressions after placement of the implant for 15 years. It's just very odd, and it makes a lot of sense. It's just very odd why people aren't doing this right now. But I think I know why, because the internet is filled with pictures of beautiful emergence profiles. And people are forgetting the fact that emergence profile is not the most important thing. A beautiful emergence profile is created by a healthy implant with healthy tissue. So if you work on preserving the tissue and preserving the bone around your implant, you will, eventually what you want is for the soft tissue to just hug your final restoration really nicely. You don't want a beautiful tissue before the final restoration. That's just useless. So that's one thing. The other thing is, I think we have a question on the right side. It says, it's from Dr. Zahlan to all panelists. It says, immediate loading for full arch needs experience. It's not easy to obtain the result that you showed finished. Of course, it does need a lot of experience. And I think Professor Mohi can answer this much better than I will do.
I think full arch, when we try to initiate people to guided surgery, for example, we always ask them to start with partial dentalis. Full arch rehabilitation, it needs to have absolutely all the other parameters already under control, because you have some small problems like how to put the provisional in the best 3D positioning as you use it during the plan. Because this is another story. You have a provisional and you need to put this provisional in the best position to have the same occlusion like on your computer. And this is quite difficult. Now we have guided support for the provisional. We have we can guide the bone reduction. We can guide the provisional itself. So we have many options to do immediate loading for full arches with the best outcome. But it's not something we have to do as a first case when we are starting guided surgery. So and what is quite pity, what I saw in Morocco is that people they think that they can be efficient with 1, 2, 3, 4 implant, but they try to start with guided surgery when they have a full arch, because they consider that the full arch is something difficult, and it's the only cases where they can need guided surgery. I have almost 30 years of implantology behind me, and I'm using guided surgery for absolutely any kind of case, all the cases, because every time I see how I can do it freehand and how it's done with the guide, I see that I really respect the dimensions for the papillae, for all those, for how deep my implant must be regarding the emergence profile. All those things are more easy on the computer than even if you're really experienced surgeon. So this is don't go for full arch, guided or not guided, if you don't have any kind of experience in implantology. The question. It's not because you will do it guided that you will succeed in a full arch. You need to have some few cases before on a single or a partially dentalist. This is the answer for. Okay, it was really a pleasure to have you, Dr. Sam. Always the big smile, and always explaining things with a lot of humility, even if you're one of the most active members of Digital Dentistry Society. I cannot finish this session without talking about Digital Dentistry Society, which is today the biggest society dealing with digital. And we have a huge conference in Italy, and you will be present, I suppose, in Lac Como in October, and it will be a really state of the art in digital dentistry for absolutely all the aspects of digital dentistry. So I know that you're a really active member of this society, and we are really looking forward to have some of your brainstorming coming up to our internal studies done inside the Digital Dentistry Society, just to understand more what is the best accuracy we can have, the best tool we can use. All those things are still inside a lot of multicentric studies. A lot of researchers are working on different things, and I really hope that you will join us more for the scientific part, to have papers together and to do some job to give to the attendees, to the general practitioners, to the implantologists, the real information regarding the iOS, regarding the DICOM files, how to deal with, what are the best tools, what are the best procedures, which workflow is the best. All those things are very important to set with the guys like you, Omar. So very happy.
شكرا جزيلا بروفيسور محي، ربنا يخليك. I would love nothing more but to work with you and with the rest of the DDS team. It would be my honest pleasure to be a part of scientific research that the DDS is doing. So yeah, let's see what the future holds.
Inshallah. Thank you so much for the ASDI. Thank you, Dr. Spelli.
I want to thank you too, Professor Jafar Mouhi, and I want to say that you are the elect president of DDS, Digital Society, and thank you very much, Dr. Omar Sam, for your conference, and see you soon, inshallah. Shukran jazilan.
Inshallah. Shukran jazilan.
Thank you. Bye-bye.